Hi ma'am, who are our PCO patients exactly?
Polycystic ovarian disease is a condition of the ovary where the size of the ovary has increased and the outer part of the ovary, which we call as a cortex, has got many small 2 to 6 millimeter size follicles, and regularly in normal women one follicle grows and ruptures. This doesn't happen in these women, and small follicles produce AMH, which is higher in the patients with polycystic ovarian disease.
Okay ma'am, I understood. And how do we diagnose these patients?
I told you the pathology in PCO is the small follicles producing testosterone. Usually females have two sex hormones, estrogen and progesterone. They have very low or negligible testosterone in their body. But the PCO women, because of these small follicles producing testosterone, which is actually a precursor of estrogen, they have a higher circulating testosterone level in their body. And so their physical features look more like males. So they have, male-like hair distribution on their body, like hair on the upper lip, the chin, the anterior abdominal wall, medial side of the thigh, on the calf muscles. They have android obesity, that is more fat on the nape of the neck, on the back, on the abdomen. They are overweight. They have irregular periods, and usually they always feel hungry. And these women are prone to diabetes later in their life. So clinically, male-like hair distribution, irregular menstrual cycles, an ultrasound picture of polycystic ovaries, which is a large ovary more than 8 cubic centimeters and having more than 12 to 15 2 to 6 millimeter size follicles. When all this is seen, we diagnose them as women with polycystic ovarian disease.
PCO drilling is useful for which kind of PCO patients?
PCO patients, when they come to a fertility clinic, they are treated stepwise. The first step that is taken is to tell them lifestyle management, that is reduce carbohydrates in their diet and increase exercise and reduce weight. Along with that, they are given ovulation inducing tablets in increasing dose, and an ultrasound check is done to see whether they are ovulating or not. And a good 20 to 30% patients do ovulate and conceive with this therapy. The rest of them who fail to ovulate with rising doses of tablets, in those we go for laparoscopy and ovarian drilling. So here, with the help of a monopolar needle, we put a scope, we take another puncture and we put a monopolar needle, and there we puncture this thickened wall of the ovary. And after we drill holes in the ovary with monopolar current, most of the testosterone comes out and the number of follicles existing in the cortex decrease. And with this, we see that many patients start ovulating spontaneously. Another few 10 to 12%, 30% may require tablets, and they do start responding to tablets which they were not doing earlier before PCO puncture. And the third is 10 to 12% patients may require injections, that is gonadotrophins, injections of FSH, which are the chief hormones that bring about ovulation. And with this, these patients do ovulate and a good number of patients conceive. So overall, after laparoscopic drilling, we expect 50 to 60% patients becoming pregnant with conservative treatment.
Are there any risks associated with this procedure?
If the ovaries are drilled too much, that is, if too many punctures are taken on the ovaries, then they can fail and the woman may just have no eggs left at all. So care should be taken. And secondly, if the ovary is not polycystic ovary, if it's just ovary with good reserves, it should not be punctured. Again, her AMH can fall, the number of eggs can decrease, and she may go into menopause.
Okay, thank you ma'am.